Good evening, everyone. My name is Rigo Garcia, and I'm the Executive Director of the Hemophilia Foundation of Southern California. Welcome to HFSC's 2023 Industry Forum. Bienvenidos y buenas noches a todos. Mi nombre es Rigo Garcia y soy el Director Ejecutivo de la Hemophilia Foundation of Southern California. Bienvenidos a nuestro seminar sobre los productos que están por venir. Casey, next slide, please. Esta noche, este seminario será traducido al español. Por favor, si pueden oprimir el botón que dice interpretación, que se ve como el globito hacia abajo de la página, y seleccionen español para escuchar esta presentación en español. Y tenemos intérpretes que nos van a ayudar hoy día con este seminario. Okay. Muy bien. Gracias. So again, welcome everybody. Our pipeline forum consists of two parts. The first part being this webinar, and the second part being our in-person event that will take place this Saturday at the Pasadena Community College. This event is meant to provide information and knowledge of products that are to come. Today, we have three amazing doctors who will present on three different topics. Many of you know them already as you receive care from them. So I would like for all of you to write any questions you have in the comments section. Once all three presentations are over, we will review all questions, and please ask away. Now, I would like to present Casey, our Senior Events Manager, who will provide information on some events that are coming up. Casey?
Hello, everyone. Welcome. Just a brief reminder for everyone, if you're not registered for this Saturday's event, we do still have a few spots open. So if you're not registered, we'd love to have you join us. That's going to be, as Rigo said, Pasadena City College, 9 to 1 p.m. Each attendee ages 3 and up will receive a Six Flags tickets. Also, light breakfast and boxed lunch will be provided. You're going to get to hear about all these great products for treatment and hear from all the different companies. We really encourage you to come if you're not already signed up. If you are, we're excited to see you. And I'll breeze through the rest really quickly. Coming up on February 8th is our first webinar in our Empowerment Forum series. We did this all last year and we are going back to it this year. The first is going to be our What's New in Legislative Advocacy. We're going to have Josie Gamas from NHF and Lynn Kinst from the Hemophilia Council of California going to just tell us about what's currently going on, what's going to affect you, what you can do to advocate for yourself. It's going to be a really great program. It's going to be February 8th. That link is live. You can visit our website to sign up. Our Women's Retreat 2023 is going to be March 18th through 19th. It's going to be at the Marriott Irvine Spectrum again this year. It'll begin Saturday at 9 and it'll end Sunday at 11. We do also have day passes if you do not want to stay over, but you'd like to attend for the day, which is good for both days. We're looking forward to having everyone. We have registration open. We encourage you to register soon as this event always sells out. So definitely, if you're interested, for women and girls, usually ages 12 and up, we'd love to have you. And also upcoming, we are having our Mujeres and Bro webinars on February 15th. We're having our Mujeres webinar on March 1st. We're having our Bro webinar. We would really like to hear from you what programming you would like to see. What topics are you interested in this year? What would you like us to cover? Please join our webinars and give us the feedback so we can provide to you something that is meaningful and something you are interested in. And last but not least, camp registration is now open. So July 16th through 21st is camp at the Painted Turtle this year. Spots are limited. We encourage you to apply early to get in. And as anyone who has filled out this application knows, it is a beast. So definitely start it early. You know, there's a lot to get through. You can always call us at the foundation for any assistance you need with this. But we're so excited to be back at camp again this year. So please apply. We can't wait for that. And then, of course, our disclaimer that any information presented tonight on this webinar, it's not medical advice. It's not intended to be a substitute for medical advice or diagnosis or treatment. Please seek the advice of your physician or qualified healthcare provider if you have any questions, and do not disregard medical advice or delay seeking it based on any information presented tonight. And I also should mention, I forgot that all of the links to our events are on our website, hemosocal.org. Please head over there to sign up for all the events. We can't wait to see you this year.
Great. Thank you so much, Casey. And just so everybody knows, like as Casey mentioned, we do have some space available for our in-person event taking place this Saturday. I did place the link in the chat. But as Casey mentioned, all of our events have the link, and that's at hemosocal.org. So now we are really excited to get started with today's event and in our today's program. Our first speaker will be Dr. Kwan. Dr. Kwan is the medical director of Orthopedic Treatment Center and adult hematologist. She will be presenting on extended half-life products. Dr. Kwan?
Am I unmuted? Yes. So thank you for that, and welcome everybody to tonight's event. Today I'm going to be talking about extended half-life factors. And again, for those of you who don't know me, I'm Doris Kwan. I'm the medical director of the Orthopedic Hemophilia Treatment Center, and we specialize in taking care of adults with bleeding disorders. So let's move on to the presentation. Get this to work. Yes, so here are my disclosures. And this is just a brief outline of what I'm going to be talking about today. Begin with just a very brief introduction, review current treatments, standard half-life, focus on extended half-life products, and then the last slide or two is just going to be an investigational product for extended half-life factor. So I know this is a very rudimentary, and most of you already know this, but hemophilia is a bleeding disorder, and it's a result of a clotting factor or coagulation factor deficiency. Factor VIII deficiency is hemophilia A. Factor IX deficiency is hemophilia B or Christmas disease. The frequency is hemophilia A is 1 in 5,000 male births, hemophilia B 1 in about 30 to 35,000 male births, and approximately 20,000 individuals with hemophilia in the United States. And hemophilia, the severity is based on the factor level, with severe hemophilia being less than 1%, moderate hemophilia defined as 1 to 5%, and mild hemophilia is 5 to 30%. With severe hemophilia, patients may have spontaneous bleeding, and it's mostly in the joints, or otherwise known as hemarthrosis. About 80% of the bleeds that are experienced by those with severe hemophilia results in joint bleeds. Moderate hemophilia, there can be spontaneous bleeds. It's less frequent than that is severe hemophilia. Patients bleed with minor trauma, prolonged bleeding after surgery, or dental extractions. Mild hemophilia, again defined as 5 to 30%. No spontaneous bleeding, generally speaking. Bleeding with moderate or major trauma, prolonged bleeding after surgical or dental extractions. And in hemophilia care, the primary goal, what we try to do is to prevent and treat bleeding, and that goal is 0 bleeds. The optimal management for those with severe hemophilia is prophylaxis, regular infusions of something as recommended by NHF, MASAC, and the World Federation. And people with hemophilia are really best managed in a comprehensive care setting, like your hemophilia treatment centers. So hemophilia care, this is just a timeline, and I'll go over this quickly. So before the 1990s, hemophilia was treated with initially in the 1950s with infusions of plasma or concentrates made from plasma. The first factor concentrates were available in the late 1960s, 1968. First factor concentrate was available. And then in the mid 1970s, freeze-dried concentrate was available for home infusions. And in the mid 80s, we had the first virally inactivated factor concentrates available. Just to remind people, in the early 90s, there were discoveries of viral problems and viral infections such as HIV and hepatitis. And so that led the way to discover virally inactivated factor concentrates. In the 1990s, heralded the advent or the approvals of the recombinant factors. The first recombinant factor was factor VIII in 1992, and in 1997 was the recombinant factor IX approved by the FDA. And so in 2003, we had the first third generation factor approved. And it wasn't until about 10 years later, in 2014, that the first extended half-life factor concentrate was approved by the FDA. So there was a long period of time, of 10 to 11 years, where there was no new products. But then after 2014, a number of factors were approved. And then in 2017, this heralded the era of what we call non-factor treatments that was approved initially in 2017 for patients with inhibitors, and then later for all hemophilia A patients with or without inhibitors. And then finally, I think a huge breakthrough just recently, and oh, by the way, Dr. Soni will be talking about the non-factor therapies that are available. And in last year, I think there was a huge breakthrough where the first gene therapy for hemophilia B, was approved in the United States. And Dr. Young will be speaking about that. So now I'm going to be talking about extended half-life factors. So the current hemophilia factor therapies, this slide just shows the factor VIII recombinant products that are currently available in the US. And you can see in the different categories here, this is the names of the different products available, the manufacturers, the structure of the factor VIII, the half-life, and the approval dates. And so we have recombinate, Advate, which is made by Takeda, Zinta was made by Pfizer, Novo 8 by Novo Nordisk, Lubic by Octapharma, Kovaltry by Bayer, and Afstyla, which is made by CSL. You can see a number of them are either full-length factor VIII products or B domain deleted factor products, Zinta and Lubic, or B domain truncated, the Novo 8 or the Afstyla. And here are the standard factor IX products. Again, the name, the manufacturer, half-life, and approval times. Benefix, Rixubis, and Ixinity with the different manufacturers. And again, the half-life shown here. And the current extended half-life hemophilia therapies that are in the US. So some of the benefits of the extended half-life factors is, number one, to reduce the number of intravenous injections with factor prophylaxis regimens. As you know, it's a burden for hemophilia patients to inject their factor, for example, factor VIII every other day. With the extended half-life factors, you can reduce that number of infusions by up to 30%. And then you can achieve higher trough levels using extended half-life factors. And the goal, of course, is to avoid all spontaneous bleeding episodes with the goal of having 0 bleeding events. And of course, we want to improve the health-related quality of life of all of our patients. And so shown here is the mechanism of half-life extension for the current hemophilia factors. There are products on the market that are what we call protein fusion molecules. So there's an FC fusion molecule where the FC portion of the human IgG molecule is fused to the factor. And then there's the second type of protein fusion is what we call the albumin fusion. And albumin has a long half-life. And I'll talk specifically in the next slide about the specific mechanism of how the half-life is extended. And the last way that these factor therapies can be, half-life can be extended is through pegylation. So more specifically, for the mechanism of half-life extension, as I mentioned, through fusion proteins, and this is shown on the left side of the slide, through the half-life extension through fusion proteins, we have the type of FC fusion where factor 8 or factor 9 molecule is fused to the FC region of the IgG molecule, or there's a albumin fusion where specifically the factor 9 is fused to the albumin. And both half-life extension through these fusion proteins is through a natural pathway of IgG recycling through a cell. So you have the fusion proteins that have receptors on them. And normally the cells take up proteins, and the neonatal FC receptor is present in these endosomes. We call these endosomes. And the fusion protein allow the proteins to bind to the neonatal FC receptor and escape lysosomal degradation or breakdown. The molecules essentially, if they're able to bind to the neonatal FC receptor, which is represented by these sort of pink things on the vesicle, you can escape lysosomal degradation or breakdown because it gets diverted. If you are binding to these receptors, you get diverted and back up to the surface. The molecules, again, are recycled. So if you do not bind the neonatal FC receptor, you're directed to the lysosome. And so these molecules shown in the yellow here don't bind the neonatal FC receptor, and they get placed into the lysosome where are they degraded. And the proteins that bind to, again, the neonatal FC receptor get diverted and delayed from degradation in the body. The other mechanism that factor gets a half-life extension is shown on the right side, and it's called pegylation. So pegylation essentially creates a cloud around the attached molecule, and the molecules then are too big to be cleared by the kidney. So on the top part of this panel, half-life, this is a normal protein, and it gets cleared by the kidney, so through renal clearance. So this is a normal molecule that hasn't been modified. And when you modify it in this later part, the lower part of the slide through pegylation, so these brown represents the pegylation onto the normal protein. So you get pegylation. And so this molecule now is too big, and the protein bound to the PEG can avoid rapid clearance in the kidney. So those are the different ways that you can get half-life extension. And so the factor 8 extended half-life therapies are shown here. Again, names of the molecules. We have a lactate, which is made by Sanofi. We have a Dynavate by Takeda, Jivi, which is manufactured by Bayer, and Esperat, which is manufactured by Novo Nordisk. The mechanism of extension, so the lactate is an FC fusion factor 8. The Dynavate is a pegylated full-length factor 8. Jivi is a pegylated B-domain deleted factor 8 molecule, and Esperat is a glycopegylated B-truncated domain factor 8 molecule. The half-lives are shown here, and the approval dates are shown in the last column. And factor 9 extended half-life therapies are shown on this slide. The different molecules include Alprolix, which is an FC factor 9 fusion protein, Idelvion, which is made by CSL Behring. It is the albumin fusion factor 9, and then Rebi9, which is made by Novo Nordisk, is a glycopegylated factor IX molecule. And you can see the different half-lives of the factor IX molecules, and the approval dates are shown here. And my next is the next to last slide are the investigational molecule that I wanted to mention. And this, again, is still investigational. It's being reviewed right now by the FDA. Some people might know it as BIV001, otherwise known as FNS-octocog alpha, which is a mouthful to say, I have to admit. And it is based on the recombinant factor VIII Fc fusion molecule. So here we have in the blue represents the factor VIII molecule, and the Fc fusion is shown in the yellow here. So again, it is an Fc fusion factor VIII and extends half-life through the neonatal Fc receptor mediated recycling pathway. And this molecule has been modified with a covalent linkage to what we call a D' D3 domain of von Willebrand factor. And this D' D3 prevents binding to the endogenous von Willebrand factor. So it decouples it from the von Willebrand factor mediated clearance. And it confers partial protection for degradation to factor VIII normally afforded by the von Willebrand factor. And it's also half-life is extended through what we call extend insertions, which are made of naturally occurring amino acids. Again, it provides protection as well as increased half-life, and it contains what we call a thrombin cleavable linker. So what happens is if the factor VIII is needed in the body, these linkers are cleaved and it forms the Fc recombinant factor VIII that can be utilized in the body for clotting. And so the half-life is shown in this slide. So the molecule is currently in phase 3 trials, and the results are being reviewed by the FDA. But in the phase 3 trial, the dosing in the clinical trial was once weekly with 50 units per kilogram, or 50 IUs per kilogram of FNS-octocog alpha. And the pharmacokinetics are shown in this left-hand side of the slide, where you have the factor VIII activity over time at days after infusion. And note that this goes out to 14 days. And you can see after a 50 unit per kilo infusion, it goes up to approximately 100%. After about 3 or 4 days, you have about 50% of it remaining, 46%. And out to 7 days, the level of the factor VIII is 10%. And in the calculations, they found that the half-life is approximately 41 hours. So you can see that this may simplify and ease the burden of infusions, because this would be given once weekly instead of where standard factor would be given every other day. So in summary, we know hemophilia is a bleeding disorder resulting from a deficiency of either clotting factor VIII or IX. And prophylaxis is the optimal treatment to avoid the consequences of the repeated bleeding. Factor replacement has been the mainstay of treatment, and the extended half-life products can ease the burden of care by decreasing the amount of infusions that one has to do, or patients have to do, and it can also increase the factor levels that you can achieve. However, prophylaxis can also be done through non-factor therapy, which Dr. Soni will talk to you about in a minute, and other emerging therapies such as gene therapy, which Dr. Young will talk about, may even further ease the burden of care. So I will let Dr. Soni take over from here.
Great. Thank you so much, Dr. Kwan. And as Dr. Kwan mentioned, next will be Dr. Soni. Dr. Soni is the medical director and pediatric hematologist of the Center for Inherited Blood Disorders, or CIBD, and he will be presenting on non-factor replacement therapies. And again, continue to add your questions to the chat, and we will follow up with them. Thank you. Dr. Soni, take it away.
Right. Hi, my name is Amit Soni. I'm from the Center for Inherited Blood Disorders. And I always like this slide because it is a miracle of what actually happens to form a clot. So we'll be a little bit more explicit here on the second step. So we'll be talking about non-factor replacement therapies. So as Dr. Kwan noticed, prophylaxis still has a significant treatment burden and expensive costs, even with extended half-lives. Current prophylactic practices don't prevent all bleeding episodes, and complications still occur securing venous access, especially those of us in pediatrics. Inhibitors affect about 20 to 30% of severe hemophilia A and about 3 to 5% of severe hemophilia B. And inhibitor treatment is already complex, intensive, and costly. So wouldn't it be great if we could provide a constant steady state rebalance of the hemostasis system, or provide a constant steady state of factor production instead of peaks and troughs of prophylaxis therapy? So as Dr. Kwan had mentioned, with the traditional standard half-life, you get these peaks and troughs of factor correlating with the peaks and troughs of hemostasis. With the extended half-life factors, you do see some improvement, but you still have some peaks and troughs. What I'm going to be focusing on is the non-factor therapy, where you're not correcting necessarily the factor level, but you're trying to improve the hemostasis. And then Dr. Young will be talking more about gene therapy in the next session. So a way that you can look at this is to think of a scale where you're balancing both bleeding and clotting risks. So in a patient with hemophilia and number B, you're more likely to have more bleeding. But if you add a procoagulant, you can balance out the scale. Or if you take off an anticoagulant, you can balance out the scale. So you can think of maybe adding a procoagulant as adding maybe an offensive player back on the field, and taking off an anticoagulant as taking off a defensive player on the other team. As Dr. Kwan highlighted, there's been multiple treatment options that have evolved. For us, emicizumab was approved in 2018. And now we have other rebalancing therapies that really are looking at replacing the hemostasis function. As you can see, these rebalancing therapies in the red are for hemophilia A, and they also can work for patients with hemophilia B. So these rebalancing therapies can work for both. This is a busy slide, so we'll go through one section at a time, but what we'll highlight is a little bit of update on emicizumab, MEM8, as well. Talk about fitusiran. We'll talk about the tissue factor plasma inhibitor with these 4 medications. And then we'll also talk about SERPIN PC, activated protein C. So first we will talk about just a slide that I used in our previous presentation about the products that were available at that time. For emicizumab, it is a bispecific antibody that works on the function of factor 8, where it binds factor 9 and factor 10. Again, instead of having factor 8 in hemophilia A, you're deficient in factor 8, and Emi kind of replaces that function. In the earlier trials, there were some cases of thrombomicroangiopathy and thromboembolism. But after modifications and limitations of using HTC products, that those complications have seemed to be resolved. I'll just skip ahead because this is already an FDA approved product where you can receive the medication once a week, every 2 weeks, or every 4 weeks. What I do want to highlight is with the last time that we talked, we summarized the Haven 1 through 4 clinical trials, and also this one from Japan. What's been new since our last presentation that's been published has been Haven 5, where they looked at the Asian Pacific population, 12 and older with inhibitors. And what they did in this study is they looked at once a week emicizumab versus every 4 weeks. And they compared it to a population of patients receiving no prophylaxis. So they felt in the Asian Pacific region, there's a lot of burden of disease. So they wanted to compare it with prophylaxis. I'll skip through a couple of slides here, but you can see that if you do not receive emicizumab or no prophylaxis, your annual bleed rate is 27, whereas those that did receive prophylaxis in either arm, the annual bleed rate was down to 1%. And those that did have bleeding complications that did not receive prophylaxis, those are the patients that bled 3 or more times primarily, whereas those that were on emicizumab had fewer bleeds. This just shows that the medication was pretty constant throughout. What was just released this past December at ASH was looking at the Haven 7 study. The Haven 7 study is primarily looking at pediatric patients less than 12 months. What they had was 54 participants, and what they noticed was that there were various different types of bruising and bleeding, but they noted that most of the bleeding was traumatic, 14. None were spontaneous. They also looked to see if there were any serious adverse events, which there were none. And they did note that there were no thromboembolic events or thrombotic microangiopathy. As those have been in clinical trials, an SAE could include anything such as tonsillitis or upper respiratory infection. So always good to look at those as we're going through the information. So that's kind of a brief update for emicizumab. It's still being used for other indications in other age populations. Next, we'll talk about MIM8, which is kind of the novel next generation factor VIII mimetic bispecific antibody, also given subcutaneously. Again, because it's a factor VIII kind of replacement, it's only for patients with hemophilia A. It has a unique molecular structure that recognizes some different epitopes or markers than emicizumab. Anti-emicizumab antibodies do not appear to react with MIM8. And thus far in early clinical trials, it reports a 15-fold greater ability to normalize thrombin generation and in vitro compared to emicizumab. What was recently released at ASH was the multiple ascending dose. So as they go through clinical trials, you start with the low dose and then you work your way up and look for any complications. What they found in patients that were in cohort 1, 2, and 3, kind of the lower end doses, that there were more adverse events or bleeding, whereas those with the higher doses had less bleeding. This just showed that patients, for instance, all of the cohorts 1, 2, 3, and 5 are all weekly doses, whereas cohort 4 was looking at every 4 weeks, kind of similar to emicizumab. So this showed that this has a potential looking at safe doses, and it'll further be tested in additional clinical trials. But that is also coming in the pipeline. Next, we'll talk about fitusiran, and fitusiran works on antithrombin. So again, it kind of removes kind of someone on the defensive side. If you're thinking of playing sports, if you're on offense, you're removing an inhibitor. So these are some of the original slides that I had in my first presentation. Essentially, fitusiran works on the production or the RNA process which is needed to make proteins. And what it does is it ultimately decreases the production of antithrombin 3. I'll skip through some of these previous slides, and just as a reminder, the study had been on hold back in 2017 for a cerebral thrombus. And during that time since, and the study has been started and stopped, there's been additional thrombotic events. And what the study has now done they have now modified the protocol. So now they're looking to target the antithrombin range between 15 and 35%. So now instead of getting fitusiran every month, you start off with a 50 milligram every 2-month dose. And then depending on your level, you can adjust to once a month dosing, and it could fluctuate between as high as 50 milligrams or as high as 80 milligrams per month, depending on your level. So there is a tighter window of acceptability for the antithrombin 3 range. We're still waiting for additional data to come out after these modifications have been made. Next, we'll look at another inhibitor. This is the tissue factor pathway inhibitor section. And we'll talk about these 4 medications here. And tissue factor, another way of looking at the clotting cascade is once a clot starts, it starts with the tissue factor 7, it comes down this way. The tissue factor pathway inhibitor, if you find something that inhibits this inhibitor, then you continue to have this pathway be available if you have a deficiency of factor 8 or factor 9. So tissue factor pathway inhibitor actually has 3 domains, Kunitz domains 1, 2, and 3. Some medications initially use both domain 1 and domain 2. Others have used just domain 2, which binds to more of the factor 10A component. So concizumab is a product that is currently still in clinical trial. I'll skip through some of that, but it is a monoclonal humanized IgG4 antibody, and it specifically binds to the Kunitz 2 domain. And in this publication that came out in 2022, they looked at different dosing and escalation of dosing. So they would start at 0.15 and may even escalate out to 0.25. And what they found, and apologize for this, but they found that the overall annualized bleed rate was 4.8. And the annualized bleeding rate, bleeds per year, was 6.4 for the extension. They found that few were spontaneous and more were in the joints. So they were able to show that with these dosings that there had been effective treatment, but as you'll see with these rebalancing agents, the annualized bleeding rate is now kind of the metric that folks are going to use to determine if it's effective or not. Then with concizumab, there were additional 3 thrombotic complications that then occurred, which then halted their phase 3 clinical trial. And after dose modifications, they then continued their phase 3 clinical trial. And this is the Explorers, one of the phase 3 clinical trials is the Explorer 7. And this is looking at patients with inhibitors. And what they found was that patients had decreased annualized bleed rate down to 1.6 versus 18.3 if you're not treated, and in hemophilia B, 2.2 versus 7.2 if you weren't treated. So it showed that at these lower doses, after the modifications, that the medication is still having a a positive enhancement of hematolosis, but there was no thrombotic complications since the restart. Marstacimab is a human IgG1 monoclonal antibody. It's also designed to bind to Kunitz-2 domain of the tissue factor pathway inhibitor. Again, with dose escalation, I should go back. Concizumab is a once-a-day medication. This medication now has been trialed as a once-a-week medication, and the data also shows that there is a decrease in annualized bleed rate compared to those that do not receive the medication. MG113 also is similar to concizumab in that it is a IgG4 antibody designed against Kunitz-2 domain. Clinical trials are still ongoing for that. And there was a previous medication that also was an IgG2 monoclonal antibody, and this was designed to bind to both the Kunitz domains 1 and 2. Unfortunately, 3 patients developed central nervous thrombosis, and that led to the closure of that study. We'll talk about next anti-activated protein C, which is the body's natural protein to break down clots. Again, this is taking off a defender from the field if you're thinking in sports analogies. So Serpin PC, normally activated protein C works with a cofactor called protein S, and it inactivates factor 8 and factor 5. Thus, it inhibits clot formation. What Serpin PC is it's a recombinant serine protease inhibitor, and it's designed to decrease the activity of your protein C levels. So in this information that was provided at ASH this past December, they looked at data, and they found that in the open label extended over an 18-month period that there were no thrombotic events. They also noted that there was a decrease by 93% of annualized bleed rates if you look at the mean. So they looked at both once every 4-week dosing as part 3, and they looked at part 4, which was every 2-week dosing. There's a little bit better decrease annual bleed rate when they gave the medicine twice every 2 weeks as opposed to every 4 weeks. So there's more information, more clinical trials ongoing for that product. And then just because we were talking about sub-Q, I came across this as well. This is a phase 3 dose selection of a medication that I won't even try to pronounce. But what this is this looks at looking at factor 7 subcutaneously. So they looked at data looking at IV versus sub-Q, and they found that in these patients, they're going to go with this dose in this dose finding process of 60 micrograms per kilo. They found that this reaches the target in about almost 80% of the patients after 1 dose. And if they gave 2 doses, it would reach more than 90% of patients. So this is kind of interesting looking at recombinant factor 7 that could be given sub-Q as our patients with hemophilia still continue to have bleeding complications even with these newer products. So in summary, we have a little bit more information about emicizumab and its use in the real world in different populations. MIM8, which might be a version 2 of the same kind of concept of emicizumab. We've talked about fitusiran, which decreases the antithrombin component. We've talked about tissue factor pathway inhibitors and the various aspects in different domains that they interact with. Again, these 3 interact against domain 2. And then we've talked about activated protein C, and if you decrease those, that if you inhibit that protein C and bring the protein C levels down, that you're also rebalancing the hemostasis. So I will conclude my presentation there. Thank you.
Great. Thank you, Dr. Stoney, for that information. And finally, we'll be hearing from Dr. Young. Dr. Young is the director of the hemostasis and thrombosis program at Children's Hospital Los Angeles and pediatric hematologist. He will be focusing on gene therapy. Dr. Young, go ahead.
Yeah, well, I'm going to apologize because I've got 9 minutes. That is not even enough time to do 3 of my slides. And I'm sure the audience has questions. And so I think that it was a bit of an ambitious program for today. But I suggest that when we reconvene, that maybe we set aside, a good 30, 40 minutes or so, maybe 30 minutes at least, for gene therapy, because there's a lot to cover. And I'm afraid that if I even start, people are going to leave with more questions than they even have answers. So, because it's 7:52. So why don't we, Rigo, if that's okay, I'll turn it back to you. We can let the audience have, whatever's left here, 8 minutes or so for questions, because I'm sure they have questions for Dr. Kwan and Dr. Soni on their talks, and I'm happy to jump in if there's questions for me, or if there's any burning questions on gene therapy. I think that'll be more productive use of the time, to be honest.
Absolutely, Dr. Young. And one of the things that we can do is that we can touch base and definitely set up a time where we can have a session on gene therapy, since I know there may be a lot of questions, like you said, and I agree with you there. So thank you so much. And we'll definitely, I apologize for the time, but definitely we will, as you see, a lot of great information and some great questions. So we will touch base, Dr. Young, and follow up and set up a session with you, if that's okay.
Yeah, absolutely. Absolutely.
Great. Thank you. Thank you so much. And we did have some great questions that came up in the talk. So I will pass this along to Casey, who will follow up with some of the questions that we have for Dr. Kwan and Dr. Soni.
Yes, absolutely. And please feel free to put your questions in the chat now, and we can go through and ask those as well. And you know what, I will spotlight all 3 of our HTC doctors just as they're answering questions, just so we can see them while they're talking to us. So the first question was for Dr. Kwan. I'll start there. And that was, does PEG for extended half-life break down to be cleared through the kidney? And then if so, what would cause TRUF? Oh, let me unmute you, Dr. Kwan.
So I'm sorry, I didn't get the last part. So yes, it is broken down eventually and it is cleared. There doesn't appear to be any accumulation of PEG. But I didn't get the last part of the question.
Yeah, the second part would be, if so, then what would cause the TRUF? TRUF? TRUF. I'm pronouncing that incorrectly.
So normally, when I went through that whole cycle of breakdown, eventually the molecules are broken down and the PEG is excreted. So just normal protein breakdown is what causes the levels to actually go down and the trough level.
Thank you. Our next question was, which company is, if you can answer, which company is involved in investigational therapy?
Oh, I think they were referring to the BIV001 or FNS octocog. And so the parent molecule is the FC factor 8 fusion protein. That's a lactate, is the trade name. And that company is Sanofi.
Thank you. And then the last question I had are, what are some concerns about an accumulation of high molecular weight PEG?
Well, the accumulation, I guess that they would be concerned that there could be accumulation in different organs, that there was in at least the the Novo Nordisk Aspirat, no, sorry, Rebinine, that there was some accumulation in some of the neural cells, I believe. But that hasn't been correlated with any clinical findings.
Okay, thank you. My next question that we have is for Dr. Soni. And it was when you were talking about clinical trials, wanted to know, are there any clinical trials being offered in Spanish?
Because of our patient population in Southern California, we always try to get a Spanish consent from the pharmaceutical companies. And if they don't provide one, we do have staff that can translate and interpret those, but we have not run into any hindrance of enrolling a patient in a clinical trial for any of our Spanish-speaking patients.
Yeah, just to jump in, most clinical trials will offer the option of having the consent forms translated. So I know Dr. Young, as well as Dr. Soni's HTCs, they all have clinical trials, and the option is to be able to translate them into Spanish.
Yeah, I want to make this point really clear. We obviously serve a very large, probably majority Latino population, and we very much want to serve Spanish-speaking patients as exactly the same way we serve everybody else. In fact, ethically, we are bound to do that, and we are required to do that. So I have a lot of clinical trials in my center, and we have enrolled many patients whose parents only speak Spanish. The adult patients, most of them are English speaking. So the adult patients with hemophilia, generally they're second generation, or even if they're first generation, they've gone to school here and they've learned English. But even if we have an adult Spanish speaking patient, we have consent forms for them. But in my center, we've enrolled many patients on trials whose parents only speak Spanish. We have interpreters in the clinic. We have Spanish consent forms, and I can also speak Spanish, not so well, but I can answer questions in Spanish as well. So for whomever asked that question, and for all of you out there, you should not hesitate to come and participate in clinical trials. You'll be treated just the same as everybody else, whether you speak English or not, whether Spanish is your primary language, or, to be honest with you, even other languages as well.
Yeah, as long as the consent form can be translated, you can request it.
And just a follow-up question to all three of you. Is there a way where the Hemophilia Foundation of Southern California can assist with these clinical trials, or any information that you might want to share where we can pass along to our community members?
I think on the website there was, it probably needs to be updated, a link to where each of the centers have clinical trials. And so I think there might be contact information there too. So you can refer them, for example, if there's pediatric trials and they live in Los Angeles, you can refer them. If they're interested in doing some cutting edge new therapy, you can refer them to Dr. Young, or if they're an adult patient wanting to participate, then you can refer them to me in Los Angeles and to Dr. Soni's site if they live in Orange County.
Yeah, and I'll just say that, I mean, we have a lot of clinical trials at Children's Hospital Los Angeles, where we do take care of children and adults as well. And I will tell you that for any patient right now, I'm scrolling through my bank of clinical trials, but I would say essentially any patient with hemophilia A or hemophilia B of any age, whether they have an inhibitor or not, I probably have a clinical trial that they could potentially participate in. And so certainly they can feel free to contact me. I mean, they can contact you, and you can route them to me if somebody's really interested in learning more about clinical trials. Because yeah, we have, I don't know, about 15 or 20 of these open. And really, I can't say 100% for sure that every age group and for every inhibitor, Hem A or Hem B, is all represented, but certainly most of the different breakdowns are represented.
But the clinical trials are not just interventional drug trials. There are also other types, participation in CDC, those sorts of things too. CDC's,
great.
I think it's more like questionnaires or quality of life type of things that might be available, even if you don't want to do a drug trial.
Perfect. Great. Thank you for that information. And we'll make sure that we share that on our website and we keep that updated. So I'll reach out to all three of you so we make sure we have that ready to go for all of our community members. Thank you.
I would just like to add, in addition to clinical trials, some of the information, even from the NHF, isn't always in Spanish. So if you as a foundation want to continue that fight for all of us, that would be helpful as well.
Yes, of course. I think the last question of the night, this is going to be for Dr. Young. Is there a disadvantage of not replacing actual factor VIII while on Hemlibra treatment, as in, are there long-term effects to being factor VIII deficient?
Well, I mean, that question can go to all of us. It's a good question. We're still learning about Hemlibra as it's fairly new. However, as best as we can understand it, factor VIII has just one function in the body, which is to help make a blood clot. And there is, as of yet, really no concrete evidence in people and limited evidence in animals that there's other functions that factor VIII has. And so with that in mind, if you're using a drug like Hemlibra, which is essentially substituting for the coagulation function of factor VIII, and if coagulation is the only function of factor VIII, then really you're probably not missing out on anything if you're using Hemlibra and not infusing factor VIII. I'll say that that is not 100% certain. There is still research and work that needs to be done about that. Speaking of clinical trials, there is a trial called Haven 7, which is enrolling patients less than 1 year of age to go directly onto Hemlibra. That trial is fully recruited now, so we don't have any room for any more patients. The reason I mention it is that trial is going to follow patients for 7 years who are likely only going to get Hemlibra or maybe a little bit of factor VIII here and there, only if they have a bleed. And they will be in that trial measuring a lot of different things, including the one area that people get concerned about is the bones that we've heard. And so they will be measuring blood tests that are looking at how the bones are functioning, as well as doing MRIs and as well as doing other tests to make sure that these patients, as they're growing, that their bone function is normal. And that's going to be over 7 years. So these children will be followed from their first year of life through their 8th year of life. And I think that'll give us a lot of information about, is there something that, factor VIII is so needed for in those young years, probably, if anything, that's when you would need it. So we're still learning a lot, but at least as of the moment, if you're asking me, am I concerned if I have a patient on Hemlibra who is not getting any factor VIII exposure and leading to potentially other medical problems? My answer is I don't believe that that's the case. But again, that's not a certainty.
Thank you. And Dr. Soni or Dr. Kwan, was there anything you wanted to add just before we close that out for the night?
I think to piggyback on Dr. Young, I know there's other trials that are looking at joint health for patients that are on Hemlibra, because if you're only getting corrected to a mild category, how does that affect the joint? So there's a lot of longitudinal studies that are going on that we'll continue to see. But yeah, right now I don't have any initial qualms of starting a patient on Hemlibra based on the information that we currently have at this time.
Yeah, our site has a joint health using Hemlibra also, joint health study with emicizumab.
Great. Well, thank you all once again for this great information. Dr. Kwan, Dr. Soni, again, thank you for such a great information. Dr. Young, again, we apologize, but I think one of the things is that gene therapy is an important topic that I feel a lot of people have a lot of questions. So I agree with you to give it some more time, and we will touch base with you so that we can set up a follow-up session to today so that we can discuss more gene therapy and make sure that if there's any more questions and give you proper time as well to be able to cover that. So thank you